Thank you very much, and thank you for organizing committee for inviting me. So to start with, the topic was really difficult. Finding out what's new updates in anticoagulation is really hard. There hasn't been many, so I tried my best to highlight some of the new. So the outline, I'm going to just go through the roughly some of the guidelines from the 2018, which has been reviewed July 2022 by the American Society of Hematology. You must have noticed now there's too many societies producing guidelines. The American College of Chest Physicians are still producing the guidelines as well. Other authorities, including in Europe, are producing it. So that would be my first part of the talk. Second part, I'll just go through the hot topic of updating the diagnostic criteria for antiphospholipid anti-syndrome. And lastly, I'll just present one of the abstracts that was presented at the ASH meeting, which I find really interesting in trying to answer a very big question. Which one is better, apixaban or rivaroxaban or warfarin in atrial fibrillation and VTE? So I'll just start with a case, and this is relatively, is actually a real patient, except my patient was a 14-year-old. So he's a 17-year-old boy, presents with one-day history of dyspnea on exertion and one-week history of right leg pain. He is previously healthy and does not take any medications. He has no family history of significance. His weight is 140 kg, his height is 175 centimeters, his BMI is 45.7, vital signs stable, Doppler of the lower limbs and CTPA have confirmed DVT and pulmonary embolism. So the first question is, he needs anticoagulation, definitely. So what are we going to start him on? Unfractionated heparin, low molecular weight heparin, DOACs, all have been approved as a first-line therapy. Now, definitely unfractionated heparin, if the patient is unstable on that, you want to admit the patient, intravenous infusion, then that would be the choice. But what would you do? And if you decide you're going to go with low molecular weight heparin, the only one available in Saudi Arabia is enoxaparin. So what would be the dose? Very commonly, we get this asked by the junior colleagues that the insert tells you that 120 is the capping dose for enoxaparin. Should we give him 1 milligram per kg exactly, or should we go with the capping dose? And do we need to monitor anti-10A in this patient because he's overweight? So actually, the guidelines helped us in answering that question. Now, the first recommendation is actually go by weight base. So you give him 140 milligrams twice daily. I was taught this. I'm teaching this to my fellows, but at least there's a body of evidence, the American Society of Hematology, who have decided on that. You have to take these guidelines with a grain of salt. So they always, whenever they're mentioning the word suggest, that's a very weak recommendation. And that's why you see the only +1 on it. The other recommendation, which was also nice, that you actually do not need to monitor for anti-10A levels in these patients. I used to teach them to do monitoring in overweight or underweight patients. Occasionally we see patients who weigh 30 kgs and they're adults. So again, probably in overweight patients, they're recommending not to monitor that. And basically, how did they reach that? It's based on retrospective data, looking at how many times did they actually adjust doses based on anti-10A testing, and there wasn't many times. So they ended up saying it's not cost effective. You don't do changes in dosing. You probably don't need to test for that. What about his obesity? If somebody wanted to start DOAC and he said the patient is quite stable, yes, he has some pain or shortness of breath, but I can start him DOAC, which has been approved upfront without any bridging. So the International Society on Thrombosis and Hemostasis produced a guidance in 2016. And I just wanted to show you how these guidance were reached. Basically, they looked at retrospective data from all the randomized controlled trials, also from the phase 4, which is basically prospective data collection observation studies. And not all DOACs have actually evidence. The biggest evidence probably is from the rivaroxaban trials. Apixaban does have some evidence, but it's lower, whereas dabigatran apixaban doesn't have any evidence on that. So actually in those studies, there weren't many obese patients to get that much data on them. And you will not see a randomized control trial in this population as well. Nonetheless, they said that, and this was before, so up to 120, you can safely start DOAC as a therapeutic for these patients. If your patient is above 120, then rivaroxaban, who has a higher evidence, is or apixaban would be the drugs of choice. And you can use them in both settings of treatment or prophylaxis. Remember, these DOACs are approved in prophylaxis post-hip and knee replacement. Whereas due to lack of evidence or lack of pharmacodynamic or pharmacokinetic data, edoxaban, betrixaban, and dabigatran are not recommended to be used in these situations. All DOACs should not be used in post-bariatric prophylaxis just because of uncertainty about the observation of these medications. So again, this is from the International Society on Thrombosis and Hemostasis from, I think, 2021. It's really helpful for our clinical practice. These are, again, low weight or of evidence on them, but nonetheless, they're endorsed by the ISTH. So we continue with the case. So he started on low molecular weight heparin based on actual body weight, and he's also started on overlapping warfarin or vitamin K antagonist. After 8 days, his INR is therapeutic and low molecular weight heparin is stopped appropriately. You see him in follow-up in 3 months, and the decision is made to continue with vitamin K antagonist for secondary VTE prevention. 5 months later, he requires an elective surgery for a pilonidal sinus. So how are you going to manage that? And that's really interesting. So would you postpone procedure by 4 months to lower the VTE risk? Interrupt vitamin K before procedure, give him peri-procedure bridging with low molecular weight heparin, or interrupt vitamin K before procedure, give peri-procedure bridging anticoagulation with unfractionated heparin, or just interrupt the vitamin K and do not provide any bridging and go ahead with the surgery and resume after surgery. So as you would know that it's been already 3 months, more than 5 months, so it's out of the acute phase or acute period of risk of embolization, and it's appropriate just to stop the vitamin K 5 days before, continue on, do the surgery and resume afterwards. So that was what's endorsed by the guidelines here also, and that's based on strong recommendations. And while in DOAC interruption therapy, that's a very nice one as well. If your patient is on a DOAC, you do not need to bridge them. There are the guidance how you manage perioperative DOAC management, and there's no need for bridging these patients. And how we decide whether it's an acute, high risk, or moderate risk, or low risk. So low risk patients, basically more than 12 months previously, VTE more than 12 months, no other risk factors. VTE 3 to 12 months, classically we call them at moderate risk, and less than 3 months is the higher risk period. For those patients, we usually either you do bridge or sometimes you may consider IVC filter insertion. Okay, so the case doesn't end. So interrupt vitamin K and he goes for the surgery, uneventful, and after surgery, appropriately, he started back on vitamin K. 3 years down the road while he's playing football, which is a very huge problem with young people being on long-term anticoagulation, he falls on his head and has a large subarachnoid hemorrhage with midline shift. Glasgow Coma Scale is 9, his INR is 2.4, and you called for the appropriate management because he requires surgery, or actually neurosurgery. So what would be your option? Either give him IV vitamin K alone, prothrombin complex concentrate, fresh frozen plasma, IV vitamin K and PCC, IV vitamin K and FFP. And as you would say, the right option would be IV vitamin K and PCC. As you know, PCC or four-product prothrombin complex concentrate has a half-life probably because 6 to 8 hours, and you need the vitamin K to take over after that. So we actually, guidelines mention administering both together. So, but if the patient has a prolonged INR and he has no clinically relevant bleeding, then you just need to hold the warfarin. You don't need to give them any vitamin K and let the warfarin drop as long as the patient is competent, lives nearby, and he's close to health services. Whereas life-threatening, as we said, you need the four-factor prothrombin complex concentrate. And also, as you see here, these are recommendations based on low-quality evidence just because of the lack of randomized control trial in these populations. So, a new case, so 70-year-old male on rivaroxaban 20 milligram daily for VTE prevention after recurrent unprovoked pulmonary emboli. Past history, hypertension, epilepsy, seen in remission of anti-seizure medications for 5 years. He's seen in the emergency department with frequent melena times 48 hours. Last dose of rivaroxaban was today, 4 hours ago. hemoglobin has dropped from 12 to 6 grams, blood pressure borderline with tachycardia, and he has a diagnosis of upper GI bleeding exacerbated by rivaroxaban. So the patient is presenting with acute life-threatening upper GI bleeding while on an oral direct 10A inhibitor. What management would you suggest for his DOAC-associated bleeding? And as you would say, cessation of definitely stopping the rivaroxaban. Would you give him 4-factor? Yeah, that's a correct answer. Or you may want to use andexanet alpha. That's a commercial name, but its scientific name is coagulation factor 10A recombinant inactivated ZOZO. So first, we will definitely stop the rivaroxaban. Then either you can choose giving him an andexanet alpha or the 4-product PCC. Both are endorsed by the guidelines. And there's none of them is better than the other because there is a lack of trials looking at which one is better. There is retrospective data saying that probably 4-factor PCC is as good as andexanet alpha. Also, there's an issue with andexanet alpha, whether you need to repeat the doses after 6 hours. That really depends on if you have ongoing bleeding or the surgical procedure is taking too long. But definitely, you can use either or in these situations if you have whatever you have available. So, if the patient was receiving dabigatran, what management would you suggest for him? And this has been clearly in the phase 2 trials of idarucizumab, which is the Pradaxa-bind, the other name for it, which basically binds the medication, so the specific antidote for dabigatran. I don't think it was a randomized trial. It was all based on phase 2 trials, so probably that's the reason for the weak evidence. If the bleeding is controlled and the patient condition improves, and this is a very practical question, we always are faced that when do you resume anticoagulation? And I think because the patient in the scenario is a VTE patient, so recurrent venous thromboembolism, the correct answer would be 2 weeks up to 9 months. So it's in the guidelines mentioned that within 90 days of the bleeding. But again, if your patient was anticoagulated for a different reason, more serious one, then you have to reconsider whether to resume it earlier or not. Not in DOACs, but for example, on people who have metallic valves and on warfarin, probably would be very uncomfortable putting him 2 weeks without any anticoagulants, so probably earlier on that. But definitely for DOACs, what sounds reasonable is 2 weeks within the next 90 days to resume anticoagulation. So I highlighted the remarks from the guidelines, so this recommendation specifically applies to patients who require long-term or indefinite anticoagulation, are at moderate to high risk of recurrent VTE, are not at high risk of recurrent bleeding, and are willing to continue anticoagulation therapy. So you have to keep in mind all of these remarks. So that was the first part. I didn't go through all the other points in the guidelines. I just picked up the ones really clinically relevant. Now, I know all of us interested in antiphospholipid syndrome have seen this new classification criteria. As you know, antiphospholipid is an autoimmune disorder characterized by venous or arterial thrombosis and or pregnancy morbidity in the presence of persistent laboratory evidence of antiphospholipid antibodies. The manifestations ranges from asymptomatic or arterial or venous thrombosis, pregnancy morbidities, which can have different definitions. You'll see that in a minute in a slide. Microthrombosis, non-criteria manifestations. So the old criteria did not include many manifestations, for example, thrombocytopenia, pulmonary hemorrhages, and catastrophic antiphospholipid syndrome. So these are the manifestations that this syndrome can present in. Sapura criteria, very old criteria developed from 2006, and we have been waiting for probably 10, 15 years for them to be updated. Remember, these were unprovoked venous or arterial thrombosis or poor pregnancy outcomes as defined in the criteria, plus you needed a positive antiphospholipid antibody which was persistent for 12 weeks. Limitations, it did not include other manifestations of antiphospholipid syndrome, for example, thrombocytopenia, heart valve disease, levator reticularis, excluded patients with pre-existing thrombophilia, other thrombophilias, and some criteria needed more clear definitions, especially the pregnancy loss ones. So what's the differentiation between, what's the difference between classification criteria and diagnostic criteria? When I was a rheumatology resident, and I think everybody, I thought that rheumatology was really easy. Every disease has just some criteria you memorize and you get to the diagnosis. Unfortunately, all those criteria are developed for research purposes. So the goal of developing classification criteria is to homogenize your patient population for studies, not to get to a diagnosis. When you develop diagnostic criteria, you want to include every possible patient, and you don't want to miss that. So you want to be more specific with your classification criteria, but you want to be more sensitive and specific with your diagnostic criteria. You may lose some sensitivity in the classification criteria, which is acceptable. We are now midway between insurance and reimbursement. Eventually, we'll be having a universal insurance system. So the classification criteria should not affect billing or for the patients, whereas diagnostic are made for that. And as well as classification criteria should not affect your treatment management plan, where diagnostic criteria is made for the management decisions. Anyhow, so the American College of Rheumatology and the European League Against Rheumatism developed these criteria with the goal of to achieve high specificity relative to the revised Sapporo criteria to improve homogeneity in antiphospholipid syndrome research. They went through a modified Delphi system, went through 4 phases of the criteria, and eventually the patients, in order to go through the criteria, should have 1 clinical event and 1 evidence of antiphospholipid before you start applying the criteria to them. I also highlighted here that they have different levels for the antibodies, anticardiolipin and beta-2 glycoprotein, with a moderate level and high level as defined in the slide. And they reached this, so it became more complicated. So actually, they have 6 clinical domains, and you have your laboratory criteria. What's interesting, now most of you know that phosphatidol, inositol antibodies and prothrombin antibodies have been associated with antiphospholipid syndrome. And personally, I was expecting that will make it to the guidelines, but unfortunately, it did not. And the reason behind it, which is I think very appropriate, that those antibodies do not occur separate from the 3 previously mentioned antibodies. So that's why they did not include them. Now, they really defined in very detail the obstetrical criteria. They included thrombocytopenia, they included pulmonary hemorrhages, cardiac valve disease. And they have some terms that it was for the first time for me to learn that, but basically livedo racemose or livedoid vasculopathy is a very specific presentation, and those are the images I had to look up from Google and print it out because I never heard about them before. But anyhow, so to get to the diagnosis, you need to score 3 points at least from the clinical criteria and 3 points from the laboratory criteria to reach a final diagnosis of antiphospholipid antiphospholipid syndrome. And now, did they achieve what they aimed for, which is higher specificity? And yes, they did. So they validated their new criteria compared to Sapporo criteria on 2 different cohorts, and they did achieve that. Reminded you the sensitivity was a bit lower, but that's totally fine for their purpose of developing the criteria. My 2 bits on that will be, we have used the Sapporo criteria, which again was a classification criteria, not a diagnostic criteria, and people have already started using these criteria. There are already online calculators for the new criteria. You have to take it with a grain of salt. You have to think twice how to use these criteria. Yes, definitely they are helpful, but again, there are occasions where they may not be able to answer all of your questions. So we will be using them, people and physicians will be using these criteria, but definitely judge your patient case by case and decide on what's the best appropriate treatment for him. Now, in the last few slides, I'm just going to show you this abstract, which was an oral abstract presented at the American Society of Hematology 2023 meeting, which was titled A Comparison of Bleeding Events Among Patients on Apixaban, Rivaroxaban, and Warfarin for Atrial Fibrillation or Venous Thromboembolism. Now, as you know, both have been approved for atrial fibrillation, or all 3 medications are approved. Both have been studied separately in randomized controlled trial against warfarin as a non-inferiority trial, and the indications are, as mentioned before, atrial fibrillation and VTE. But then the question always comes up, We also have in the kingdom, in the private sector, most of the private sector do have edoxaban as well, so we have a third DOAC available to us. Dabigatran, as Prof. Mentioned earlier, it's really falling down out of favor, and I think we won't see it in the near future, possibly. So this was an attempt to answer which one was better in terms of bleeding, in terms of prevention from recurrent thrombosis. We won't be able to see a randomized controlled prospective trial of these studies. So what they did basically was a retrospective study of registries, and they took their data from warfarin DOAC clinics. So yes, there are in North America clinics which are called DOAC clinics, where people on DOACs are monitored on a regular basis, and actually recommended to do that in your practices. And they looked at a huge number. They excluded patients who were treated for valvular AFib, anticoagulated less than 3 months of follow-up. And that's the number of patients they got. What they matched them in a propensity matching system, matched them for age, sex, alcohol, tobacco abuse, atrial fibrillation, venous thromboembolism, comorbidities, and they looked at different parameters, including also concomitant medications like aspirin, estrogen, non-steroidal antiplatelet therapy. They also calculated HAS-BED scores for them, the Carlson comorbidity index, the duration of follow-up as well. What they were looking for was basically thrombosis and what type of thrombosis they developed, also bleeding, emergency visit, hospitalization, death, and requirement for blood transfusion. So, apixaban versus warfarin, I would say this was just confirmation of the randomized control trial where it does have non-major, apixaban has higher non-major bleeding, but definitely for major bleeding, it's lesser than warfarin, and we all know that from all the DOAC trials in randomized control trials. Rivaroxaban, very similar to that, except that in the major bleeding, probably slightly higher. It is higher there. Non-major bleeding was higher with rivaroxaban. Any bleeding was higher with rivaroxaban. Thrombosis recurrent didn't differ between warfarin. So what about both of them together? So which one was better, rivaroxaban or apixaban? As you can see, people had major bleeding more with rivaroxaban. They had also non-major bleeding more with rivaroxaban. Any bleeding was higher with rivaroxaban. So it does help us. So the strength of this trial was basically in a large, robust data set. Bleeding and thrombosis outcomes were measured. It was a real-world data. The drawback on it, or the limitations, that it's an observational data, so there's always room for selection bias. It's a retrospective data, so recall bias is also an issue. Potentially underpowered, that could be also. The numbers were not very high, but this was just localized to the Michigan area. Again, that's a geographical limitation. Data on MI may not be well captured, and there was no data on adherence of patients as well. So the conclusion from their point was for patients on oral anticoagulant, bleeding was highest with rivaroxaban, followed by warfarin, and then apixaban. And that has been shown in randomized controlled trials as well, that apixaban has the lowest rate of bleeding. Thrombosis was higher with apixaban compared to warfarin, seemingly largely driven by other thrombotic events. Thrombotic event rates were otherwise similar between apixaban, rivaroxaban, and warfarin. We observed apixaban to be associated with lower mortality than rivaroxaban and warfarin, but that was just an observation. As I said, it's very difficult to conduct a randomized controlled trial prospective comparing both of these DOACs. But at least that may help us in slightly deciding for our patient population which would be the best DOAC to use in your centers. And with that, I finish my talk, and thank you for listening.